minimally invasive, transgluteal approach. This video has been produced from a book source. We would like to thank the editor Friedan Kirschbaumer, Friedan et al., 2015, Operative Approaches in Orthopedic Surgery and Traumatology. Principal indications: total joint replacement, hemiarthroplasty, femoral neck fracture, femoral neck osteotomies, juvenile slipped femoral, capital epiphysis, hip joint synovectomy. Positioning and incision. The patient is placed in the supine or lateral decubitus position. If the supine position is chosen, part of the buttock on the operated side projects over the edge of the table so that the soft tissues can shift posteriorly and the trochanter region is covered with as thin a layer of soft tissue as possible. The skin incision is made over the greater trochanter parallel to the axis of the leg and is 5 to 11 cm in length. The distal limit of the incision is projected on the inferior border of the acetabulum, figure. The relation of the trochanter to the acetabulum on X-ray can be used to assist orientation. The iliotibial tract is incised parallel to the skin incision. This incision can be extended by up to 2 cm subcutaneously, deviating approximately 15 degrees anteriorly at the distal end and 15 degrees posteriorly at the proximal end, figure. Splitting of the fascia lata parallel to the skin incision at the level of the innominate tubercle. The incision is extended up to 2 cm subcutaneously, curving slightly in a distal, anterior and proximal posterior direction. The bursa is incised parallel to the skin incision from the tip of the trochanter extending distally over the vastus lateralis. The insertion of gluteus medius is then divided from the trochanter tip, figure. Subperiosteal dissection continues as far as the capsule, detaching the tendon of gluteus minimus, which remains joined with gluteus medius. Incision of the tendinous insertion of gluteus medius close to the trochanter. The incision begins at the trochanter tip and curves slightly distally. Dissection continues to the joint capsule with division of the tendon of gluteus minimus. Exposure of the hip joint capsule. The anterior portions of the joint capsule are dissected free, with a Cobb elevator. A curved narrow Hohmann elevator is inserted anteriorly between the origin of rectus femoris and the anterior margin of the acetabulum. A straight or curved Hohmann elevator protects the cranial part of the joint capsule. Another Hohmann elevator may be inserted between iliopsoas and the joint capsule, figure. Exposure of the joint capsule, protecting it with Hohmann elevators. L-shaped incision or inverted T-shaped incision of the joint capsule and subsequent resection. 1. Trochanteric bursa. 2. Gluteus medius. 3. Vastus lateralis. 4. Lateral circumflex femoral artery and vein. An L-shaped incision is made in the right hip joint capsule, or a reverse L-shaped incision in the left joint capsule. The joint capsule is then elevated anteriorly. If necessary, the capsule is mobilized far medially in the direction of the lesser trochanter using a Cobb elevator, figure. Insertion of a Hohmann retractor on the anterior border of the acetabulum. The leg is flexed approximately 20 degrees. The capsule is dissected distally as far as the lesser trochanter with a Cobb elevator. 1. Head of femur. 2. Neck of femur. 3. Vastus lateralis. Wound closure. The capsule can be closed superiorly by an interrupted suture. The muscles are reattached using side-to-side suture of the gluteal muscles to the remaining tendon stump on the greater trochanter. 2 or 3 full-thickness sutures are placed to reinforce the tendon of gluteus minimus. The iliotibial tract is closed with absorbable interrupted sutures. Dangers. Injury can occur to the superior gluteal nerve by an incision too far proximally when dividing gluteus medius above the tip of the trochanter. Thanks for watching. Subscribe Orthopedics Trauma in YouTube.